Hello people, namaste, welcome back to my channel. In previous videos I discussed two videos about rickets. Next, this is a continuation of another topic of rickets, like refractory rickets. In this video we will discuss about the refractory rickets. Okay, refractory and means no response to vitamin D supplement. After giving vitamin D supplement, discussed previously, like vitamin D supplement for 12 weeks, daily vitamin D supplement I discussed for greater than 1 year, less than 1 year, less than 1 year 2000 international units, greater than 1 year 3000 international units, and also along with calcium supplements like 50 to 75 mg per kg per day. So after giving this treatment there is no response to vitamin D supplement. It is called as refractory rickets. Okay, what are the refractory rickets? What are the disorders seen in this refractory rickets? Why this refractory rickets occur means because of familial hypophosphatemic rickets. Okay, first one is familial hypophosphatemic rickets. Next, vitamin D dependent rickets. RTA means renal tubular acidosis associated rickets. CKD means chronic kidney disease associated rickets. So four types of refractory rickets are present. First one, last one is kidney, CKD. Next is RTA, it is also kidney but renal tubular acidosis. Next one is vitamin D dependent rickets. Next one is familial hypophosphatemic rickets. So these two are important, vitamin D and familial. Okay, these two are dependent because these two only inherited disorders. These two are inherited disorders, whereas familial hypophosphatemic rickets are X-linked dominant, whereas vitamin D dependent rickets are autosomal recessive. We will discuss each one of them. First one is familial hypophosphatemic rickets. Hypophosphatemic rickets. See, previously I tell familial hypophosphatemic rickets are which type of inheritance? X-linked dominant. See, X-linked dominant inheritance. This is the most common inherited form of rickets. In both two, most common is familial hypophosphatemic rickets. See, in this familial hypophosphatemic rickets, what is the gene mutation occur? Inheritance means gene mutation. No, which gene mutation means PEX gene. PEX gene, which is code for phosphate regulation endopeptidase. See, first I will tell what is PEX. PEX gene mutation. PEX means PH means phosphate. PH means phosphate. E means phosphate regulation. E means endopeptidase. X means like X-linked gene means X gene. Like PEX gene. This comes under PEX. PEX gene codes for the phosphate regulator endopeptidases. Generally, this PEX gene secretes endopeptidases. So this is PEX means phosphate regulator endopeptidase X gene. This is the, but in this refractory rickets of familial hypophosphatemic rickets, PEX gene mutation will occur. What is pathophysiology? How it occur? Normal. See, this is normal condition. This is the rickets condition. In normal PEX gene, their PEX gene will produce this endopeptidases. What are endopeptidases? Endo means endogenously. Peptidases means it's inactivate the proteins. Some proteins will be present. No, that proteins will be inactivated by these peptidases, like breakdown. Something will occur, but protein will undergo some inactivation. Endogenously inactivation of proteins will done by the endopeptidases, which is secreted by the PEX gene normally. So because of endopeptidases inactivated of phosphatonin is one type of protein. Peptidases is inactivation of proteins. No, so it inactivates the phosphatonin is one type of protein. Phosphatonin is also called as FGF23. FGF means fibroblast growth factor. Phosphatonin is also called as fibroblast growth factor 23. Okay, this is the normal pathophysiology. If in PEX gene normal, there is endopeptidases which inactivate the phosphatonin also called FGF23, fibroblast growth factor. Okay, next, but here PEX gene undergoes mutation in this familial hypophosphatemic rickets. Okay, this undergoes mutation. Then because of mutation, no endopeptidases means no inactivation of phosphatonin. So phosphatonin is always active form. This phosphatonin, what will phosphatonin will do means it will excrete the phosphate into the urine. It excrete PO4 3 minus in urine. So because of more excretion of phosphate in the urine, it leads to hypophosphatemia. So it is called familial hypophosphatemic rickets. Hypophosphatemia because of this phosphatonin activation. Activation leads to a phosphate release into the urine. It leads to the hypophosphatemia. So this is the pathophysiology. Okay. Next comes to the clinical features of familial hypophosphatemic rickets. See, first lower limb deformities. Same I discussed previously, like genu valgum, genu varus, all these lower limb deformities we can see in this also familial inherited phosphatemic rickets. Okay. Next is dental abnormalities. Dental means pulp exposure, increased risk of dental abscess. Dental abnormalities will occur. What are the dental abnormals? Increased risk of dental abscess and pulp exposure. And here it does not depend upon the calcium levels. It depends upon the only phosphates. Because of increased excretion of phosphate level decrease is called hypophosphatemic. But here no role of calcium. So it is telling no feature of any hypocalcemia. So no tetany will occur in this familial hypophosphatemic rickets. So how we treat this condition? Only phosphate is going up, so you should give the phosphate supplementation. Phosphate supplementation is also called Joulin solution, which is the solution which contains phosphates. Joulin solution contains elemental phosphate. This Joulin solution contains elemental phosphate. First one is supplement. Next one is this PEX. See, Pexigene as general pexigene endopeptidase also called FGF23. FGF23 which inactivate the phosphatonin is also called as fibroblast growth factor. So we should here activation is occur no because of hypophosphatemia. So we should inactivate this. Phosphatonin is also called FGF. So we should inactivate the FGF23. How we can inactivate? By giving the burosumab. Mab means antibodies. Burosumab is a new drug monoclonal antibody against FGF23. Because of inactivation of this FGF23, then no phosphate will pass it excreted into the urine. So this is the treatment. What is the treatment? One is phosphate supplement, is called Joulin solution, and then one is burosumab. Burosumab is a monoclonal antibody. So these are the familial hypophosphatemic rickets. Okay. First, I discuss the familial hypophosphatemic rickets, X-linked, most common inherited form, and Pexigene, pathophysiology, and clinical features, lower limb, dental abnormalities, no features. Next, I discuss the two treatment. One is burosumab and Joulin solution. Next, we will discuss about the vitamin D dependent rickets. Okay. See, vitamin D dependent rickets is, I discussed previously, autosomal recessive inheritance. Okay, it is autosomal recessive inheritance, which is defect in the vitamin D metabolism. Here, vitamin D metabolism undergoes defect. Okay, not depends upon the vitamin D, no calcium, no nothing, only phosphate. We discussed about the phosphate. But now we are discussing there is a vitamin D metabolism defect. It leads to vitamin D dependent rickets. So vitamin D defect metabolism leads to hypocalcemic will be seen. First, we should know the metabolism of vitamin D. See, if vitamin D, how it come from the diet or from the sun. Like see, when sunlight is coming onto the skin, like 7-dehydroxy cholesterol in the skin. In the skin, it converted into the, because of UVB, generally our skin has 7-dehydroxy cholesterol. Because of sunlight, it converts into D3. In food, it comes into the D2. So next comes to the liver. By 25-hydroxylase converted into 25-hydroxy cholecalciferol. After the kidney, by the enzyme called alpha-1 hydroxylase, we converted into 1,2,5-hydroxy cholecalciferol. After that, it converts into some biological actions. Okay. So this is the metabolism. Okay. Here, in liver 25-hydroxylase, in kidney 1-alpha hydroxylase. Okay, because of 1-alpha hydroxylase, it converted into 1,2,5-dihydroxy cholecalciferol. After that, biological actions. This vitamin D dependent rickets is there now. This vitamin D dependence. This vitamin D dependent rickets are of two types, like type 1 and type 2. See, before going the type 1 and type 2, I will tell type 1 and type 2. Type 1 is because of we call it as absent of 1-alpha hydroxylase. Type 2 is called resistance to vitamin D action. See, this 1 alpha hydroxylase, if it is absent, alpha 1 hydroxylase is not present, then it is not converted into the 1,2,5 hydroxycholecalciferol now. So it is called as type 1 vitamin D dependent rickets. Next, type 2 dependent rickets, after formation of 1,2,5 hydroxy deoxycholecalciferol, but there is no biological action. Some action should be present now after the formation of vitamin D. So there is no action. It is called type 2. Resistance of vitamin D action is called type 2. Those, this is the type 1, this is the type 2. Next comes to the classification. Sorry, clinical features. Clinical features is called, first feature is classic features of rickets. Same. And before I discussed about the rickets, some clinical features, same features are present in both type 1 and type 2. So how you differentiate it is 1 alpha hydroxylase deficiency or any biological action resistances. We can differentiate by clinical features. Like type 2 have extra points. What are extra point? Ectodermal defect. Ectodermal defect like melia, epidermal cyst. Melia means some epidermis, small eruptions, like small eruptions. Epidermis is involved. Okay, ectodermal defects. Next, oligodontia, teeth decrease. Next, alopecia, hair loss. Alopecia, oligodontia, and ectodermal defects. Those three are present, then it is called as type 3. Type 2. Type 2 means resistance to biological action, resistance to vitamin D action. What are the three? Epidermal cyst and melia is called ectodermal defect. Next, oligodontia and alopecia. See how we treat this type 1 and type 2. Treatment of type 1 and type 2. At type 1, alpha 1 hydroxylase is not present, so we can give alpha 1 hydroxylase. How we give alpha 1 hydroxylase? In the form of alpha calcidol. This is the active form of vitamin D. This is the active form. Okay, we can give alpha calcidol plus calcium supplements. So should be given in type 1. Okay, in type 2. Type 2, just actions are resisting now, so we can give high doses of vitamin D. So it partially overcome the resistance and improve the symptoms. Just high doses of vitamin D type 2. In type 1, alpha calcidol plus calcium supplements. So this is the vitamin D dependent rickets. So these are the two refractory rickets. Before I discussed the familial hypophosphatemic rickets, now I discussed about the vitamin D dependent rickets. Okay. So in hypophosphatemic refractory rickets, there are 4 types now. Hypophosphatemic, like familial hypophosphatemic rickets, vitamin D dependent rickets, and RTM is renal tubular acidosis, and CKD. How you differentiate? You read about the familial and the vitamin D dependent rickets, VDD here. Now how we differentiate all 3? If the person came with refractory rickets, see. If the person approaches with refractory rickets, first you should check the biochemical values. Biochemical values means what? Which biochemical value? First, serum phosphate. Serum phosphate high or low? It is very high. I discussed in familial phosphatemic levels are very low. So if high and low, it is very high. It comes under the kidney, CKD associated rickets, because decreases the excretion of phosphate. It increases the phosphate level in the body. So it is called CKD associated rickets. Next comes to the normal or low. If it is low, then the phosphate level is low, then you can do the ABG, atrial blood gas. Then see the acidosis. If acidosis is present, acidosis is absent. Acidosis present means this is a RTA, renal tubular acidosis. If acidosis is absent, next check the PTH levels, parathyroid hormone levels. If it is high, if it is normal. If it is normal, it is called familial hypophosphatemic rickets. Familial hypophosphatemic rickets means it is normal. It is normal PTH levels and low phosphate levels. Here, because familial hypophosphatemic rickets does not depend upon calcium, but here vitamin D is metabolism, vitamin D metabolism no, so it depends upon the calcium. Here, if PTH levels are very high in response to low calcium levels, it is called vitamin D dependent rickets. Okay, it is vitamin D dependent rickets. This is the approach of refractory rickets. Okay, thank you. Please subscribe my channel. Please support us. Thank you.